Good afternoon, everybody. I am Dr. Major Vimal Raj. I am a cardiac radiologist from India, Bangalore. I would like to congratulate the organizing committee in putting together such a wonderful program, and I would also like to thank you guys for inviting me to be part of this annual conference. Today, I'm going to be talking to you on a very important and interesting topic on ARVC, or arrhythmogenic right ventricular cardiomyopathy, the assessment and prognosis. I'm going to be focusing a lot on cardiac imaging, especially cardiac MRI. The objectives for this talk are going to be to focus on the current guidelines on the diagnosis of ARVC. Then I'm going to show you multiple cases to show you what is the use of cardiac imaging in making the diagnosis of ARVC in forms of the incidental pickups, in forms of classical cases that you may come across. I'm also going to be talking about the prognostic importance of what cardiac MR will show in these patients. Finally, I'm going to try and pose some questions that often remain in the minds of people who are in the imaging sphere when it comes to ARVC. ARVC is an inherited genetic disorder which is primarily related to desmosomal genetic activity, whereby there is fibrofatty replacement of the myocardium, especially in the right ventricle. So the myocardium in the RV gets replaced by fibrofatty tissue, which tends to act as a focus for arrhythmia, leading to multiple complications in patients. The diagnosis of ARVC is primarily defined and adopted from the 2010 task force criteria, where leading cardiologists and imagers from around the world put their minds together, looked at some of the proven cases and came up with this diagnostic criteria. This is called as the revised task force criteria, whereby they have revised the prior guidelines which were given in 1997. The clinical presentation is often in the form of sudden cardiac death, especially in youngsters, it being one of the common causes of sudden cardiac death apart from hypertrophic obstructive cardiomyopathy or anomalous coronary anatomy. But when we look at adults, it may not necessarily present with sudden cardiac death, but arrhythmias or palpitations could be a common presentation. The variance of presentation in this entity since its description, and with more and more use of imaging, we are finding that there are a lot of variations from the classical pattern that has been described. That has led to the formation of a newer terminology called as the ACM, otherwise a simple arrhythmogenic cardiomyopathy rather than the ARVC. Now let's look at the different forms of ARVC that one may come across. The classical form of ARVC is the form which has been very well described. This is the one which we commonly see, where there is predominantly right ventricular involvement with right ventricular fibrofatty replacement and VT or other arrhythmia as presentation. Another variety that we have started seeing nowadays is a biventricular variant, whereby there is right ventricle as well as left ventricle involvement, whereby right predominates or left predominates, but both the ventricles are involved. In very few cases, in a small minority of cases, we started to see isolated involvement of the left ventricle, where the left ventricle primarily is involved while the right ventricle is spared. This often can be a big diagnostic challenge, especially to differentiate it from other infiltrative cardiomyopathies which tend to involve just the left ventricle. Now let's talk about the diagnosis and how do we diagnose this. This is one part of the revised task force criteria, and this being the second part of the revised task force criteria. Few important pointers that all of us have to know and maybe revise is that to make a definite diagnosis, we need two major criteria, or one major criteria with two minor criteria, or we need to have four minor criteria across all the different modalities. And one thing which I like about this classification is that It basically talks about different components of the heart and the physiology. For example, we talk about the regional wall motion abnormality or structural alterations in the myocardium. There is a tissue characterization. Then there are ECG abnormalities, which are repolarization abnormality or depolarization abnormalities. Then there is a arrhythmia component, and then there is family history component. So you can have different components from different sections come together to help you in making the diagnosis. Now, as far as imaging is concerned, we are going to focus on MRI, where we are talking about major and a minor criteria. Similarly, echo also contributes to the major and minor criteria, and family history also makes an important contribution. Let's just focus on the MRI for a second. When we look at MRI, it's very important for all of you to know that we need to have right ventricular wall motion abnormality. Either it has to be a regional akinesia or dyskinesia. So it has to either not move or move abnormally, or it has to have dysynchronous contraction. So that is the bare minimum that we should be seeing in the RV. Along with that, we look at the ventricular volumes, especially the end diastolic volume, indexing it to the body surface area. If the RV EDV is more than 110 in men or more than 100 in female, that satisfies one major criteria. If we don't look at the volumes, we just look at the function. If the ejection fraction of the right ventricle is less than 40%, then it satisfies one major criteria. Remember here, what is important is that if you have a patient who has both volume as well as ejection fraction criteria satisfying it, it is still considered as one major criteria. So you can't have two major criteria from cardiac MR. Similarly, if you have the volumes are enlarged but not reaching up to this, for example in men reaching between 100 to 110 and in women between 90 to 100, then it becomes a minor criteria. And if the ejection fraction is 40 to 45%, then it becomes a minor criteria. So as far as cardiac MR imaging is concerned, you could either have one major criteria or one minor criteria. You cannot have both. You cannot have two major criteria. You cannot have one major and one minor criteria. It has to be only one criteria. Putting it in a different way is that in isolation, cardiac MR cannot diagnose ARVC. In our real life practice, we see classical cases which appear like ARVC on MRI, but they do not match up to the diagnostic criteria if there are no other features, if there are no ECG abnormalities, if there is no histopathology confirmation, if there is no family history or there is no rhythm abnormalities which satisfy other criteria, we cannot make that diagnosis on MRI. These criteria were established, and the accuracy, the sensitivity and specificity of different parameters were looked at, and one could clearly see that the sensitivity is in mid-70s while the specificity is very, very high. For example, if you look at the male for a major criteria, the specificity is up to 90%, and in females it's as high as 98%. So these are very, very robust criteria when it comes to diagnosing ARVC. Prior to these revised task force criteria, we used to follow the 1997 criteria which was available, whereby there were more of descriptive changes rather than volumetric or quantitative abnormalities. So this was the first task force criteria which had come in, which talked about severe dilatation of RV and reduction of function. It did not necessarily quantify what was severe, did not quantify what was the amount of ejection fraction that needs to go down. So once the new criteria came, there were a lot of comparison between the old criteria and new criteria to assess and see what performed well. This was one of the reviews which looked at multiple studies, and they come up with a very conclusive answer saying that newer criteria has resulted in a significant reduction in the number of patients who would satisfy CMR criteria. So, if you may have a volume of 95 ml, you would have qualified according to the older criteria, but with the newer criteria you would not qualify. But the certain groups of revised criteria have significantly increased in number of patients which are diagnosed, which basically means that as the newer technology has come in, as more and more cardiac MRs and imaging has come in, we are diagnosing more patients, but we are actually diagnosing still much less patients than what we would have done in the older criteria, and with a high sensitivity and specificity in assessing these patients. Let's look at some of the cases, okay, and let's try and see how one would analyze a cardiac MR study. So this is a cardiac MR study where you can see the four-chamber view and you can look at the contraction of the heart. What is important is to look at the right ventricular free wall, which you can see across here, and see how it contracts. The left ventricle seems to be contracting really well. The right ventricle, you have to look closely and you start to see that there are areas of dyskinesis, areas of early bulging that one can see across in the RV free wall, which is satisfying the first statement, RV akinesia or dyskinesia. This is then followed by looking at the volume. So we do the functional assessment of these patients, and in this patient we had an indexed RV EDV of 115. This was a male patient, while the RV ejection fraction was 45. So then where do we fit this? If you look at the volume criteria, volume of more than 110, this certainly fits into that major criteria where there is increased RV dimensions and there is wall motion abnormalities. These are called as early microaneurysms in the RV free wall. So the report would go in this patient as the CMR features are suggestive of ARVC and satisfy one major criteria of the revised task force criteria. So we don't necessarily say this is ARVC, but we say that this satisfies one major criteria of the ARVC diagnosis. Let's look at another case. It's also important to know that there are some conditions which may mimic ARVC and you need to be careful about these conditions. Sometimes where the moderator band gets inserted into the RV free wall, you might see focal areas of dyskinesis, and that may trigger to think that this could be ARVC. In such conditions, it is important for us to look at the entire RV free wall and look for other areas of abnormality. And when you can see across in these images, you will start see there are multiple focal areas of aneurysmal outpouching and dyskinesis of the RV free wall, which would again be in keeping with ARVC diagnosis in this patient. Let us look at another case. This is a 35-year-old female who presented with palpitations and had a very strong family history of sudden cardiac death. What we can see is dysynchronous contraction between the LV and RV. And if we look at the RV free wall, it is easy to miss the dysynchronous or the dyskinesis that one may see in the RV free wall. So it's very important for us to closely pay attention to this. Now the same patient, when we do a short axis view, the RV free wall dyskinesis becomes very, very apparent, and you can see it is not at all contracting in a synchronous fashion. We also do delayed enhancement imaging. By that we mean we give contrast, and about 7 to 10 minutes after giving contrast we start doing imaging. And the areas where you can see this bright enhancement or contrast deposition, they are usually suggestive of fibrosis within the myocardium. So this was another case of ARVC. MRI was satisfying one major criteria for ARVC. Let's look at another case here. This is a 26-year-old female who had an ASD closed as a child and now has presented with recurrent VT. Echo showed RA-RV were dilated and they were worried that it may have been that the ASD closure was too late and pulmonary hypertension has set in. And we've done a cardiac MR in this patient. Now, look at the cardiac MR closely. When we look at the RV free wall, you start to see these areas of dyskinesis. Things are not contracting as well as one would like them. The LV and RV are also very dysynchronous in their contractions. We do the short axis images and you can see that RV is grossly dilated and it's just not contracting as well as what one would expect. You can see the inferior wall is not contracting well, and again the lateral wall has got these micro aneurysms that one can see. This again is suggestive of ARVC. We look at the delayed enhancement imaging and you start to see these patchy areas of enhancement again showing fibrosis. So another case of ARVC that we have seen in there. Let's look at a different variety of ARVC. This is a 43-year-old male who had a VT-related cardiac arrest out of the hospital and was resuscitated and brought back. Not clear family history, and when we look at the cardiac imaging, you start to see the LV seems to be working okay. You start to look at the RV, slight early microaneurysms along the RV free wall can be seen here. And then when we look more closely, you can see these nice aneurysms forming in the RV free wall. This is very, very important, called as a saw teeth appearance, where you can see all these tiny aneurysms all contributing to the underlying arrhythmia in this patient. One interesting thing to look at this patient is actually the left ventricle. If you see these left ventricle, you will see some irregular areas along the left ventricle, especially in the lateral wall. When we do contrast imaging, you're seeing the right ventricle has got fibrosis within it, but there is also this fibrosis along the septal wall. You can see some kind of eaten up epicardial areas of abnormality in the LV wall, anterior segments, patchy areas of LV involvement. So this is a patient who has got biventricular involvement, which is ARVC with ALVC, and unfortunately, although the appearances are very, very classical, but when we do the volumetric assessment, we see that it only matches up to the minor criteria. Although you're seeing nice microaneurysms, but the volume and the ejection fraction don't reach up to the major criteria. So you would report this as CMR features are suggestive of ARVC and satisfy one minor criteria amongst the revised task force criteria. This is another patient. This is a 48-year-old male patient who's been having recurrent ventricular tachycardia. And when you look at this, echocardiography did pick up another pathology, and cardiac MR was asked for it. And I just want you to have a look through this while I keep quiet for a little few seconds to see if you guys can pick up something abnormal. I told you to look for the right ventricle, so you've been seeing the right ventricle is grossly dilated in here. There is mild dyskinesis, but there's something else going on in this patient. And if you pay close attention, you will see that he's actually got an ASD. So a patient who's got an ASD with a left to right shunt, who had a QP/QS of 2, okay? Now when we do the volumetry in this patient's volumetry certainly satisfies the ARVC criteria, but because whether the volumes are influenced because of the ASD or whether they are primarily related to ARVC is a question which is difficult to answer. When we do delayed enhancement imaging, you can see RV free wall enhancement and some enhancement in the septum. This fits more towards ARVC because primary ASDs should not give you this kind of enhancement. So after seeing all these cases, it is also important to know what might mimic an ARVC and how to differentiate one from the other. If you're thinking about isolated right ventricular involvement, there are conditions like Uhl's disease, Epsteins anomaly, RVOT-VT, which can all try and mimic the RV variety. The LV variety of ARVC may be mimicking cardiac sarcoidosis or myocarditis, which can be a little tricky for us to differentiate from. This is one such case where if you look at the RV looks dilated, the function of the ventricle seems decent and there doesn't seem to be any dyskinesis. But if you look at the tricuspid valve, you will see that the tricuspid valve is apically displaced, and this is a patient with Epstein's anomaly. Another patient where we look at the RV, this was a child in his teenage, and we would see that the RV is actually dilated and focal areas are not working well, you can start to see, oh, is this aneurysmal dilatation? And then you look at the history. This was a patient of tetralogy of Fallot and who's had an intracardiac repair. So this was an RV to PA conduit, which basically is what is aneurysmal in this patient. Another conditions where one may mimic is when you start to see pulmonary hypertension, that will also have RV dilatation. Sometimes athlete's heart can also give similar appearances. This is a very interesting case, which kind of a nice teaching message in here. This was a 56-year-old male who had a VT and was known to have RCA territory infarct. So they wanted to go and do a VT ablation and wanted us to quantify the infarct size appropriately before they would go and do the ablation. And for that, we had done a cardiac MR. And you can see in here that the basal inferior wall is thinned out, is not moving well in keeping with RCA infarct. And then again, when we start looking at the RV free wall, you start to see that this is dyskinetic in the RV side. And you look at the short axis fully, and this is the RV. You start to look, and you will start to see that there are early areas of microaneurysm formations in the RV free wall. And there is dyskinesis of the RV free wall. When we do delayed enhancement, you can see there is a large infarct in the RCA territory, and then there is enhancement along the RV free wall, which is not a typical infarct region. And with this dyskinesis, it was very clear that this patient actually had a ARVC, and RCA infarction was a red herring in this scenario. So we've seen multiple cases, we've seen how we diagnose, what do we look for. Let's concentrate on some unclear concepts. The fibrofatty replacement of the RV myocardium is the primary histopathological reason for ARVC. However, it does not form a part of the diagnostic criteria as far as cardiac MR is concerned. It is easy for us to demonstrate fatty infiltration in the RV free wall in some cases, and a lot of people use that as a diagnostic criteria and call the case as ARVC. If you look at about 1/3 of the cases are wrongly diagnosed, just purely that they looked at the fibrofatty replacement and said this is ARVC, but did not look at the other criterias. Okay, it is something which can be seen in normal patients also. There is a lot of fat in the pericardium, epicardium, which could mimic that of a RV free wall. So one has to be very careful when it comes into diagnosing that. So please do not look for fibrofatty replacement of RV free wall in cardiac MR or CT at this current moment. Another concept which is very confusing or not very clear as yet is pediatric ARVCs. We find a lot of children who have arrhythmic changes. When we do cardiac MR, the RV is dilated and RV has mild dyskinesis, but we do not know whether to use the same diagnostic criteria for pediatric patients in terms of the volumes, in terms of the ejection fraction or not. One thing is that this condition is uncommon before puberty because patients often present in 20s to 40s in there. So not commonly seen, but when we see, we are not very sure how to diagnose these patients. RV delayed enhancement is another concept which is commonly misrepresented when it comes to ARVC. RV free wall enhancement, which represent fibrosis, is not equal to ARVC and can be seen in other conditions as well. So if we just see that, we should not be suspecting ARVC, but we have to use the standard volume and ejection fraction criteria in these patients. So that brings to the important question of how does MR help in management and prognosis of patients? The most important factor of MR when it comes to managing or prognosticating patients is screening of patients or relatives who are diagnosed with ARVC. So MR is excellent in that. Tarial et al. Looked at a period of 4 years. They serially followed up patients who were relatives of ARVC patients, and saw what happens to these patients serially. 1/3 of the patients in this group progressed. Almost all of these patients only had electrical parameters in the term of progression. Structural progression, the ones which would be seen in cardiac MR, was only seen in one patient, whereby the volume also just increased by 6 ml, but the ejection fraction drop was about 5%. So what this basically means is that electrical changes of ARVC predate structural changes. Okay, so if you're seeing electrical changes versus structural changes, electrical changes are likely to come much earlier than structural changes in these patients. In cardiac MR, these structural changes are what we are seeing. Therefore, if we see these structural changes, we straight away know that these patients are of a severe phenotype and are likely to have higher event risks in future. So that is a very, very important part when it comes to prognosis. Okay, if you look at patients who had electrical changes without cardiac MR features, they were at very low risk for arrhythmia over a 7-year period. But if you had MRI features along with other parameters, then you would have more likely to have risks in there. None of the patients in a study of 48 individuals without CMR changes had arrhythmia. So a normal cardiac MR or an absent features of cardiac MR seems to be protective or seems to be good for patients, while if you start seeing changes in cardiac MR, that assumes a poor prognosis in these patients. And this data can be used for ICD implantation decision. So in summary, electrical abnormalities predate structural changes. Cardiac MR plays a critical role in the diagnosis of these patients. Follow the modified task force criteria. In future, I suspect fat recognition, delayed enhancement, especially with advances in cardiac MR imaging, will form an important part of the diagnostic chain in these patients. Until then, beware of the pitfalls that I have shown you and the differential diagnosis, and I'm sure you will be able to make the right diagnosis in most of these cases. Thank you very much for your patient listening. I look forward to answering your questions.